Post-Streptococcal Glomerulonephritis in children, simplified clinical case. Post-Streptococcal Glomerulonephritis, PSGN, is a kidney disorder characterized by inflammation of the glomeruli following an infection with certain strains of group A beta hemolytic streptococcus. It typically occurs 1 to 2 weeks after a throat infection or 3 to 6 weeks after a skin infection like impetigo. Case presentation. Michael, an 8-year-old boy, is brought to the pediatric nephrology clinic with complaints of dark urine and swelling in his face and legs. This presentation is typical for PSGN and requires further evaluation. Clinical findings. Dark urine, hematuria. Michael's parents noticed that his urine has become reddish-brown, indicating blood in the urine. Periorbital and pedal edema. Swelling is observed around Michael's eyes and ankles, common signs of nephritic syndrome. Recent history of sore throat. Michael had a sore throat about 2 weeks ago that resolved without treatment, suggesting a preceding streptococcal infection. Mild hypertension. Blood pressure readings are elevated for his age, often seen in PSGN due to fluid retention and kidney impairment. No history of fever or joint pain. This helps differentiate PSGN from conditions like systemic lupus erythematosus, SLE, or henoch-Schönlein purpura, HSP. Normal growth and development. Michael's height and developmental milestones are age-appropriate, suggesting an acute condition. Evaluation and diagnosis. To confirm PSGN and assess the extent of kidney involvement, the following steps are taken. Urinalysis shows hematuria with red blood cell casts and proteinuria, indicating glomerular bleeding. Serum complement levels. Decreased levels of complement proteins, particularly C3, typically returning to normal within 6 to 8 weeks. Throat culture or rapid antigen test to detect group A streptococcus infection, though results may be negative if the infection has resolved. Antistreptolysin O, ASO, titer. Elevated ASO titers indicate a recent streptococcal infection. Kidney function tests, including serum creatinine and blood urea nitrogen, BUN, to assess kidney impairment. Renal ultrasound evaluates kidney size, rules out structural abnormalities, and assesses for signs of acute inflammation. Discussion. Michael's clinical presentation and diagnostic findings strongly suggest PSGN, particularly given his recent sore throat and presence of hematuria and edema. Pathophysiology of PSGN. Immune complex deposition. Antigen-antibody complexes from the streptococcal infection deposit in the glomeruli, triggering inflammation. Glomerular injury. Inflammation leads to proliferation of glomerular cells, damaging the filtration barrier and causing hematuria and proteinuria. Reduced complement levels. Activation of the complement system consumes proteins like C3, a key diagnostic feature. Management and treatment. Treatment involves supportive care and managing complications. Antibiotics. For active streptococcal infections, typically penicillin or amoxicillin, to eradicate bacteria and prevent complications. Fluid and electrolyte management, to maintain balance and control hypertension, often with salt and fluid restriction. Diuretics, to alleviate edema and reduce fluid overload, commonly using furosemide. Antihypertensive medications, such as ACE inhibitors or ARBs to control blood pressure and reduce proteinuria. Monitoring, regular follow-up to monitor kidney function, blood pressure, and urine output. Most children recover fully, but long-term monitoring may be needed in some cases. Prognosis. The prognosis for PSGN is generally favorable, with most children recovering within a few weeks to months. Severe cases can lead to chronic kidney disease, but long-term outcomes are excellent if kidney function returns to normal within 6 months. Persistent symptoms may require a kidney biopsy to rule out other diseases.